You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 14th, 2018. This week, I'm talking about the Apple Watch announcement, the ablate and pace strategy for rapid atrial fibrillation, CTO-PCI, assisted reproductive technology, and Dr. Ron Victor. We have to start with Apple's announcement on the newest version of the Apple Watch. Specifically, the watch and its app will notify you if the heart rate gets too low or if it detects an irregular rhythm, and the watch can do a one-lead ECG, lead 1. And Apple has received clearance from the U.S. Food and Drug Administration for the app. My colleague, Dr. Ethan Weiss, had the best tweet of the week. He wrote, quote, "I can't figure out whether today is the best day in the history of cardiology or the worst." Now let's start with the 3 positives of the Apple Watch. First, if you put on a research hat, all of this data that we collect, this big data, will surely lead to knowledge, and I think that is a good thing. And another upside, all of these watches will lead to greater health literacy about the heart rhythm. I mean, right now, people are so easily frightened by normal variations of the heart rate. I think just as my grandkids know how to work a smartphone or an iPad, the next generation of adults will know that the heart rate can get super slow during sleep and can spike during physical activity. They'll just have more knowledge. And a third positive is that the mobile ECGs like this and the AliveCor device will and are disrupting the heart rhythm monitoring industry. For instance, if I see a patient who complains of a rapid pulse or palpitations, I would typically order a monitor to correlate rhythm with symptoms. But if these patients have Apple Watches, they can do it themselves, and I like that. And of course, the corollary of that is that people can actually diagnose themselves, and this could lead to a sort of flip the classroom approach to patient care. In other words, where patients come in with a diagnosis. I think that's cool, and the doctors of the future will take on a much greater role as advisors rather than diagnosers. Now, the downsides of the watch are many, and it comes when you put your clinician's hat on. The background is that I spend most of my day in the EP clinic extracting excess fear. The most common way I help people is not by ablating or putting in devices. It's really by reassuring and educating people. And the Apple Watch will definitely increase people's interaction with the healthcare system, and that worries me because we doctors do a much better job when we're treating illness than we do when we're sorting out what's normal. And look, doctors have action bias. We do stuff. The Apple Watch will cause people to get tests, and this creates the risk of iatrogenesis. Just take, for instance, let's say this monitor that someone does shows PVCs. Well, that could lead to a stress test, and stress tests are known for their false positives. And then a false positive stress test leads to a cath, and although the risk of catheterization is low, it's not zero, and if you do it in millions of people, you're going to have harm. So the gazillions of people seeking care because of aberrations on their watch will not see EP docs or conservative docs comfortable with not ordering tests. They're just going to see their regular docs. More and more people will get on what I call the train of healthcare testing. But think about it. It gets even worse than that. Even when the watch is correct and it finds atrial fibrillation, we don't really know whether treating short duration atrial fibrillation or screen-detected atrial fibrillation is going to make much of a difference. Remember that clinical trials that showed anticoagulants were beneficial were done in patients with clinical atrial fibrillation. And of course, the average wearer of the Apple Watch is young, and this is the worried well. They'll be the least likely to have atrial fibrillation, or if they have AFib, they're young, they'll be the least likely to benefit from anticoagulation. Now that exacerbates the problem of misdiagnosis and creates a situation of overtreatment. Finally, I have to wonder why the AHA endorsed this development. I mean, I would think that the AHA's role in this would not be a cheerleader for Apple, but an arbiter of the science and a voice of reason about the potential downsides. Now, unlike the LiveCore device, which has oodles of peer-reviewed data publicly available on their website, the Apple Watch has a couple brief descriptions of 2 studies it submitted to the FDA. I don't think these have been peer-reviewed and published as of today, and I don't know anyone in the public sphere has seen the actual data behind the Apple Watch algorithm. Second topic is about ablation and pacing for atrial fibrillation. Now, I don't know about your practice, but in mine, I see a lot of older, frail patients who present with heart failure due to AFib at a rapid rate. These are common. These patients are hard to treat because they often have low blood pressure and cannot take enough AV node blocking agents. And it would be pure folly to consider them for AF ablation. There's just no way. So, the technique of ablating the AV node and putting in a pacer accomplishes perfect heart rate control, it establishes a regular pulse, and it removes the need for drugs to block the AV node. That's pretty good. But the downside of this strategy, obviously, is that the patient is now pacer dependent, and if a lead malfunctioned or the device became infected, there would be significant trouble. Of course, the other downside of a typical ablation and pacing is that single lead RV pacing can cause pacing-induced LV dysfunction in a not small number of people. So this is an unmet need for caring of these people, is why I was drawn to an RCT from an Italian-led group comparing AV node ablation plus CRT versus medical therapy. So European Heart Journal published the RCT, and it included about 50 patients in each group. The follow-up was about 1.5 years, and the primary endpoint, a composite of deaths due to heart failure hospitalization, or worsening heart failure, occurred in 20% of patients in the ablation arm and 38% in the drug arm, and that 62% reduction did meet statistical significance. Also, the composite of overall mortality or heart failure admission was reduced by 72% in the ablation arm. The ablation arm had a 36% reduction in specific symptoms of AFib. So the authors concluded that CRT plus ablation of the AV node in these patients with rapid AFib was superior to medical therapy. Now, my comments are that the first point to make is that, thank goodness, this is an RCT, which is better than so many of these other studies, observational studies or propensity match studies. Since we have so many of these patients, I congratulate the authors on doing an RCT. And what's more, it's also cool that we have an RCT done on older, sicker patients who are often excluded from more typical cardiology trials. But before anointing the aggressive and permanent strategy of ablating the AV node and putting in a device, we have to be careful here. This trial had small numbers of patients, and it was stopped early with only a small number of events, and that can increase the risk of bias. The primary endpoint also was driven by softer endpoints like heart failure hospitalization, and this is important because the trial was not blinded. So investigators could have been more apt to admit a patient in the medical arm and not admit a patient in the device arm. This trial will continue longer-term follow-up, and I look forward to that data. In the meantime, another strategy that I think deserves to be studied is the use of His bundle pacing and AV node ablation, which I've done successfully on a handful of patients, and this strategy accomplishes narrow QRS pacing combined with perfect heart rate control and no need for AV node blockers. Next topic is on CTO-PCI, that is chronic total occlusion and PCI of a chronic total occlusion. So when trialists pick surrogate endpoints to measure instead of hard outcomes, a hard outcome being death and MI, a surrogate outcome being anything else, they set a lower bar to show efficacy. So German authors of the REVASC trial set out to study PCI of a CTO versus medical therapy. They chose the endpoint of a change in regional wall motion, that is, the heart region supplied by the chronic total occlusion. Now, even though they used a very legitimate measure of wall motion, MRI, this is still a decidedly soft endpoint and a low bar. And even with that low bar, they found no change. Opening the vessel did not improve wall motion compared to medical therapy. And Super Pro journalist Steve Stiles picked the right quote. Quote, "Contrary to our expectations," said one of the investigators, REVASC failed to show a difference. And this, my friends, is why RCTs are so important. Previous observational trials of CTO-PCI had found an association of improved function with CTO, and it would make sense that opening a closed artery would improve function, especially if there was viability. But in this RCT, it did not. CTO-PCI is invasive, it's expensive, and what little evidence there is reveals no obvious benefit. CTO-PCI, therefore, is clearly a flat-of-the-curve, low-value practice. Now, one thing I did learn from Steve Stiles' story is that there is an ongoing sham-controlled trial of CTO-PCI looking at angina relief. And this is key because the Orbita investigators have shown well how important it is to use placebo-controlled procedural studies when evaluating subjective endpoints like angina. All right, fourth topic represents a little bit of a new topic for me. This is on assisted reproductive technologies. Millions of people are born using assisted reproductive technologies, and a small longitudinal study from Swiss authors, which was published in JACC, concludes that ART, or assisted reproductive technology-induced premature vascular aging, persists in apparently healthy adolescents without any other detectable CV risk factors, and it progresses to arterial hypertension. These were the conclusions. It sounds terrible. I mean, no malice to the authors who are doing important work, but I highlight this study because it is a case in point as to why journals should require a paragraph on limitations in the abstract of all papers. Now, this was a study of less than 100 kids. Of the millions born with ART, this is an uncontrolled study of less than 100, is by definition not conclusive. What's more, the measures of vascular aging define surrogate endpoints. I mean, they're looking at carotid intima thickness. These are shadows, right? Flow-mediated vasodilatation and pulse wave velocities are classic examples of surrogate endpoints. In fact, they're like surrogates squared. Now, who knows what these small differences mean? The other thing to look at in this trial is the difference in blood pressure. So in the ART group, the systolic blood pressure averaged 119, and the control group 115. And yes, I know the p-value was 0.03, but I cannot believe that a delta of 4 millimeters of mercury in less than 100 kids means anything. So of course we need to study this topic further, but these data points do not support these conclusions, even if they are published in the top tier medical journal. Final topic, I wanted to say something about Ron Victor. Dr. Ron Victor, a clinician scientist and primary author of the Black Barbershop study, recently died. Now recall that the trial, the Black Barbershop study, randomized barbershops to a pharmacist-led intervention in which barbers encouraged patrons to meet with pharmacists who then could prescribe blood pressure-lowering drugs versus a control group in which the barbers simply encouraged lifestyle changes and doctor's visits, but didn't have the pharmacist. Both these intervention groups improved their blood pressure, but the pharmacist-led group had a mean blood pressure reduction of 21 millimeters mercury more than the control group. This was an amazing trial, and I think one of the most important trials of our generation. Now, there's a New York Times columnist, David Brooks. He talks often about eulogy virtues and resume virtues. The difference, of course, is that resume virtues are things that you bring to the marketplace, and eulogy virtues are those that people talk about at your funeral. And I actually think about these a lot. Dr. Victor's pursuit of better care of an underserved population with an innovative design earns him both types of virtues. Yes, seeing this work published in the New England Journal of Medicine is definitely a resume virtue, but his dedication to helping an underserved population get help with a devastating risk factor like hypertension is surely a eulogy virtue as well. I really wanted to interview him after his presentation last year, but sadly his health did not permit it. My colleague at the Heart.org Medscape Cardiology, Patrice Wendling, wrote a beautiful piece on his work, and I encourage you to take a look at it. So that's it for this week in cardiology. I'm grateful that you listened. Again, if you like this podcast, please consider subscribing and giving us a good review on iTunes or wherever you get your podcast.
You're listening to This Week in Cardiology from the Heart.org on Medscape.